Hello, my name is Yayoi Tada. I'm a dermatologist at Teikyo University in Tokyo, Japan. Today I will talk about the pathogenesis of generalized pustular psoriasis, or GPP, and how recent advances have led to new therapeutic targets. GPP is a rare but severe inflammatory skin disease characterized by the sudden onset of widespread sterile pustules with systemic inflammation. It is essential to distinguish GPP from plaque psoriasis because their disease mechanisms and treatment strategies are fundamentally different. Plaque psoriasis is a chronic disease driven mainly by adaptive immunity, especially the IL-23/Th17 axis. In contrast, GPP is acute and explosive, predominantly driven by innate immunity with a central role for IL-36 signaling and massive neutrophil infiltration. Histopathology is particularly important. Plaque psoriasis shows epidermal hyperplasia, parakeratosis, and Monroe's microabscesses, whereas GPP is characterized by cogoid spongiform pustules with marked neutrophilic infiltration. Systemic inflammation is a hallmark of GPP. Patients often develop fever, leukocytosis, and elevated CRP levels. In the Japanese Dermatological Association GPP guidelines, edema is included in the severity score, reflecting increased vascular permeability. This case shows the edema develops in parallel with inflammation and improves with effective systemic treatment. Accurate diagnosis is critical. Clinical findings, laboratory data, and histopathology together help differentiate GPP from AGEP, other pustular dermatosis, and blistering diseases. Early recognition is essential because GPP can be life-threatening. GPP is associated with genetic abnormalities affecting IL-36 signaling, NF-kappa B activation, and neutrophil regulation. CARD14-associated papillosquamous eruption is caused by gain-of-function mutations in the CARD14 gene, leading to enhanced NF-kappa B activation in keratinocyte and increased production of IL-36, IL-8, and CCL20. CARD14 mutations are also implicated in GPP. IL-36 is a key driver of inflammatory amplification in GPP. After activation by neutrophil-derived proteases, IL-36 signals through the IL-36 receptor, activating MAP kinase and NF-kappa B pathways. When IL-36 activity exceeds that of the IL-36 receptor antagonist, TNF-alpha and IL-17 synergize with IL-36, creating a feed-forward inflammatory loop. DITRA, or deficiency of the IL-36 receptor antagonist, is a major genetic cause of GPP. IL-36RN mutations remove the inhibitory brake on IL-36 signaling, resulting in sustained inflammation. Mature IL-36 gamma is overproduced in the epidermis of patients with IL-36RN loss-of-function mutations. It suppresses corneal desmosine expression, leading to stratum corneum detachment and pustule formation. Clinically, even heterozygous IL-36RN mutation carriers may show manifestations such as geographic tongue. These mechanistic insights directly inform treatment strategies. The IL-36 pathway is a disease-specific therapeutic target in GPP, while IL-17, IL-23, and TNF pathways also remain relevant. Because GPP can progress rapidly, prompt disease control is critical. As an example of biologic therapy in GPP, I will present our real-world experience with IL-78 inhibitor ixekizumab. In 10 consecutive GPP cases, ixekizumab led to rapid improvement in PASI and JDA severity scores, often within the first few weeks. Clinical images show dramatic resolution of erythema and pustules within 2 months, indicating clinically meaningful improvement. Ixekizumab treatment was also associated with rapid reductions in inflammatory biomarkers, providing sufficient disease control even in patients with prior treatments or diverse genetic backgrounds. Spesolimab is a monoclonal antibody targeting the IL-36 receptor. This case shows rapid and sustained resolution of palmoplantar pustules, highlighting its high efficacy in GPP. In Japan, granulocyte and monocyte absorption apheresis, or GMA, is approved and reimbursed for GPP and can be rapidly introduced in the acute phase. GMA selectively removes activated granulocytes and monocytes, directly suppressing excessive innate immune activation. In our single-center study, GMA rapidly reduced body temperature, white blood cell count, and CRP levels. Within 2 weeks, erythema, pustules, and edema significantly improved without serious adverse events. In summary, GPP is a distinct IL-36-driven disease characterized by dominant innate immune activation and neutrophilic inflammation. Genetic factors explain its explosive nature and support pathogenesis-based therapeutic strategies. Thank you very much for your kind attention.